Want to go ahead and start just as soon as you're ready?
Give me 3 seconds. Can you still hear me?
Yep.
Yes.
Great. Um, there we go. Awesome. All right. Well, super excited to have Dr. Chris Feudtner here today virtually. He is a pediatrician, clinical investigator, and ethicist at the Children's Hospital of Philadelphia and the University of Pennsylvania. He really focuses on improving the lives of children with complex chronic conditions and their families. He is the chief of Division of General Pediatrics at CHOP, and over the years, he has conducted a wide variety of research projects and has been involved in developing clinical programs while also taking care of complex pediatric patients, including providing palliative care, as well as providing clinical ethics consultation. He lives outside Philly with his family, including his wife, a family physician, and 3 children, 2 of whom are now off to college, and his morning running buddy, Rita. And I think the bio that Chris provided does not even begin to do him justice. And there are a handful of individuals who are really pioneers in pediatric palliative care research, and he is one of them. But I think what a lot of us most appreciate about Chris is his mentorship. I was just talking to another individual yesterday. We were talking about how when there are particularly critical career decisions, that he is just so generous with his time and wisdom as he helps us negotiate life and academic medicine. So he is tremendously impactful researcher who has really helped a lot of us up-and-coming pediatric palliative care researchers. So really grateful for his mentorship and leadership in the field, and super excited to have him speak today.
Well, thank you very much, Emily. Thank you, Shamita, for the invitation, the opportunity to join all of you and talk about a area of research, pediatric palliative care, which can be generalized, even though that's where I'm hunkered down. This will equally apply to studies of adults far along in their aging journey, all the way to very old age. And we'll be talking about qualitative research, and I'm particularly going to try to emphasize how it can help develop, screen, and test assumptions and mental models. I can imagine initially that there may be both some enthusiasm and some skepticism about theories of pediatric palliative care. I hope to make it clear that these aren't grand theories. These can be very practical little concepts. I call them walk-around theories. People just walk around with a notion of how the world works or how it's organized. And qualitative research can help us identify what those walk-around theories might be, scrutinize them, test whether they are as generalizable or as applicable as we might think, potentially even destroy them, to realize that no, that is not an adequate little mental model, and hopefully be able to develop more accurate and useful mental models. So if you are short on time and you are only going to watch the first minute and a half of this talk, I can summarize by saying that I think it's really helpful, and I think this both as an investigator and as a mentor and an advisor to a wide range of people who want to do qualitative research, that the science that we are offering from our qualitative research set of tools and perspective is a part of a larger argument. And all of science is an argument about what is true about the world, what we can learn about the world is sort of epistemological, or the sort of what we know. And we have to be comfortable entering and engaging the argument. Hidden in this, and I'm going to make it explicit now, is the concern I have often that people who do qualitative research want to start from a place where they have questioned the whole argument idea to such a degree that their work stands outside of it. It's more of a, I'm going to start from the ground up and I will have something completely different. And while you might be onto something that will be truly enlightening, I think it is always best to connect that back to the current way that people think about different phenomenon, enter into that way of thinking about it, and engage it with an argument. Basic assumptions: we all want to make the world a better place through the science we do. We think that better knowledge will lead to better treatments, better outcomes, and a better world. And the question then becomes, how do we create better knowledge? And to that question, how can qualitative research play a role in that pursuit? One of the things that you often hear is that qualitative research cannot test a theory. It can help develop theories, and that it's theory generating. I think that this is, again, I'm going to stick my neck out here, and as I often say to parents, I'm going to be very straightforward. I'll tell you what I'm thinking. I'll tell you what I'm worried about. I won't make a promise I can't keep. I think that this really sells the work that we do short and is probably inaccurate. That my contrarian mental model is that qualitative research always inevitably arises in the context of existing theories. They may not be good theories, they may be incomplete theories, they may be theories that aren't even formalized or explicitly stated. But it's very, 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 add a couple of more varies to that, rare to encounter something where nobody has any preconceived notions. You might think, well, I'm not going to dignify those preconceived notions by calling them a theory. What I'm going to try to argue is, even if it's a really bad theory, if it's a theory that you find obnoxious or worse, it's a theory about how the world and people within the world operate. And our work is better positioned if you realize from the outset that you may be undertaking a project that is going to critique that theory and help develop a new replacement theory. This then becomes the way that we think about potentially mixed methods in either a sequential mode or a parallel mode, that you've got a theory, you do qualitative work, you refine that theory, you may then take it on to quantitative work that actually helps provide provisional evidence, and that's all we ever have is provisional evidence that a theory is correct, and that builds up enough eventually that we have consensus, but it's provisional consensus, could always find out something in the future that would change our minds about what we think is true in the world and have a new theory. Put this together outside of a sequence, and what I'm going to try to argue, and I think for many of you, the idea of quant and quantitative methods, qualitative methods, working in some kind of mechanistic knowledge production way, that they interdigitate, they can support each other, they can augment. And again, the point that I'm trying to emphasize is what they are doing is they are spinning a wheel of theory development. Let's start then with the idea of theory destruction. And I'm going to now illustrate using, I hope this doesn't come off wrong, I'm using exclusively work that I've worked on with my teams. Over the years, the team has changed, in part because it's familiar to me, and in part because I can talk about the thought process that led into the work. So for those of you who are designing projects, trying to figure out where to go, I can offer some insights of what was going on in my mind and the mind of other people. One of the things I learned writing this talk is there are many quotations about creativity and theory, and when you dig in, you actually find that none of them can you find an actual citation. So Pablo Picasso is said to have said that every act of creation is first an act of destruction, but nobody can find a place where that was written down by him or attested as a quote. But it certainly captures an insight that I think many of us have, is that often creativity is a little bit rebellious. So this is the interactive part. I'd like each of you to take just a minute here and think about when you are taking care of patients, if you take care of you, if you're clinically active, or if you're an investigator and you're not clinically active, you are aware of it because of research that you've done or conversations you've had. 5 things that you think this can't be right. Like everybody assumes this, but I don't think that's actually true. And notice here I'm using the word assumption, not theory. Most people don't walk around, unless you're obnoxious like I am, and say, well, I have a theory about this and I have a theory about that. What they're more likely to say is, well, of course. And I'll give you some examples from my own work, but before I start to do that, I'd like to just help you personalize this talk a little bit. So if anybody is willing to come off mic, if you're allowed to, and just offer up, and we'll do this for a minute, what are some things that you hear people say clinically or in research context that you think that I don't think that's actually accurate about palliative care? And if people are more comfortable putting something into the chat and somebody can monitor the chat, that would be the other way we could do this. So Wendy, I can't see the chat, but maybe
we'll take care of it. Don't worry.
Yeah, so far nothing in the chat, but everyone feel free to speak up.
I feel like I hear that Black and Hispanic patients want to die in the hospital and want more medically intense end-of-life care than non-Hispanic white patients.
okay. And there, as Emily, as you're pointing out, like you could say, I don't know, that's an interesting assumption. I don't know that it's true. I don't know that it's false. I'm not saying that this comes off as stating it, I think that's wrong, or I can't think it's right. But even if you think that's a strong assumption, we should look at that. That's enough for this exercise. Because that is a very prevalent assumption where we have some data to suggest that may be true, and probably need more to actually tease apart what might underpin that, if it is even true.
Yes, Nick, you're going to say something?
Yeah, as an ICU nurse and early on, that everyone prioritizes comfort at end of life.
All right, Nick Odom, you are not a plant. I have not paid you, correct? Right, we just need to clarify that, because that's also going to come up in one of the things that this can't be right. All right.
So can I add, and this has
Yeah.
to do with something which is so immediate right now and so real, is that the palliative care that we practice in the US cannot be translated to other countries such as India.
Okay. Thank you for offering that, and I can appreciate how that's immediately personally applicable as something you might be thinking about. All right, I'm going to move into things that I have thought. Uncertainty is about the prognosis of the patient. We cannot get palliative care involved because the situation is too uncertain. What are you talking about? Well, the prognosis of the patient is too uncertain. Like, well, that can't be right, because you guys have all told me that you know this cancer can't be cured. We'll come back to that. Early on, I was told by a mentor, when I was thinking about looking at hope, which was just simply a word that parents used a lot, and it sort of was ringing in my ear. And I was told, oh, don't study hope. Hope is the enemy. It is a deluder. It has people go down paths that are going to be not in their best interest and pointless. Parents focus only on what's best for their child, like they're monomaniacally focused on what will give the best outcome. And I just thought that that was both true but very incomplete. We'll get to that. Then Nick's point, parents accepting palliative care focus only on comfort. In fact, many palliative care teams, pediatric palliative care teams, and some adults focus on the comfort team in the name as a way of branding and marketing, but also as a sort of North Star of the cardinal product that they offer. And it seemed to me that that was important, but it was not the exclusive important thing. And we'll get back to that. And parents are born having a parental identity. This is a little bit more nebulous. It's so commonly assumed that, as soon as the baby is born into the world, and maybe even before, depending on your concepts of in utero bonding and what it means to actually have a parental identity, that immediately the mother and the father, the biologic mother, biologic father, and this would be true with adoptions and other things, that as soon as they have parental status, societally recognized parental status, they have a full formed identity. And that also seemed to us to be not quite right. So let's tackle each of these a little bit of like, where did this take us? We looked at transcripts of a project where we had interviewed people in part in a co-design project about how to initiate palliative care referrals in the pediatric oncology setting earlier in the course of disease progression of advanced children with advanced cancer. And one of the things that we noticed, both in the notes that we were taking as the groups were being run, and then again in the analysis of the transcripts, was that the word uncertainty kept popping up. It's sort of a fairly prevalent word, but it didn't seem to mean the same thing. It was not pointing at the same point of uncertainty, like what was uncertain, seemed to be smushy. You could identify in almost all the cases, you could eventually figure out what they were uncertain about, but it wasn't clear that if I said, well, there's a lot of uncertainty here, and I might be thinking about one type of uncertainty, that Smita or Wendy or Nick would be thinking about the same thing. People use the term, think that we're all in agreement, but we may actually have different targets of what is going on. In the analysis of the transcripts, we did find that sometimes people were talking about prognostic uncertainty, summarized in a question like, how do you think the patient will do? And that could have an implication for whether you will refer to palliative care. If you think that the patient is going to do really well, we don't need to refer to palliative care because we actually think that this tumor is going to be so well controlled or what have you, or in fact, cure could be achieved. Palliative care is not needed if we think they're going to do very poorly. And the degree to which we are uncertain about that will make us pause. But then there were these other targets of the uncertainty. Do I have enough information to actually even make the determination about the prognosis for the child? Which is different than uncertainty about what will happen to the kid. It's sort of layered on top of that. It can also reflect more ambivalence on the part of the person who would have to make the referral. Nobody has to do it, and other people could, but let's say the primary oncologist is in this system of care, the one who makes the referral. They could have a degree of uncertainty. They know what the prognosis is. There's plenty of information to back it up. They're just uncertain about whether this is the right time. And they're ambivalent, which may be driven more by personality characteristics and emotions. They may be uncertain not about whether they think they should do it, but they are uncertain about their ability to do it. Of can I communicate my desire to bring palliative care into the mix of the people concurrently who are taking care of the child? How well can I broach that? If I'm very insecure, I often will use the term, well, I'm uncertain that I can do this or that it should be done because I'm not sure I'm the one who can do it. There are also other players in this. Uncertainty as to how the family will react. Uncertainty, given their reaction, what will it do to the relationship I have with them? Because I've worked with them for a year. I don't want them to fire me. I don't want them to hate my guts, and we severed the relationship. I don't know how my colleagues are going to react to this. Am I going to get support from them, or are they going to be, no, you didn't do that. Come on, there's a lot more we can do here. And a lot of questioning and pressure there. And what will other medical centers say turned out to be something I had not anticipated, but came up over and over again of, we've recommended palliative care here, they're going to go talk to another center. Oh, no, 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 you're not ready for that. And feeling like that can also pose a threat to the relationship that you might have with the family when they're being told by a potential other center that now's not the time for palliative care, now's the time for some alternative, not alternative medicine, but an alternative treatment strategy. All this does, this type of qualitative research, is expand the set of possibilities of what we mean when we say we're uncertain, and refutes the idea, which qualitative work can do exquisitely, if you think it's only about one thing, it's only about prognostic uncertainty. We have now data to say, in this one setting with this one team, it was not just about that one thing. That theory is woefully incomplete. We looked at influences on decision-making identified by parents of kids receiving palliative care. This is the first longitudinal study that we did. I should have mentioned down at the bottom right, you're seeing citation statistics. So the relative citation ratio, the RCR, if you go to iCite, little I and then CITE, allows you to look at, for a given paper, how it compares to the citation frequency over time and sort of normalized for how many years the paper has been out. Your paper has, compared to other NIH-funded publications. So RCR of 1 means that you're right smack dab in the middle distribution of the percentiles. This paper is at the 76th percentile in terms of citation. I point that out because one of the things that I'm going to try to gently suggest is the more you engage in argument, the more people are going to use your paper to actually be able to make their argument that the current way we think about something is incomplete or incorrect, or that there's when we move on to some theory development, that there might be a better theory of how to look at something. And you'll see that all of these papers have RCRs above 1. That means they're outperforming, although they're strictly qualitative work, which tends to have lower RCRs. But I'm showing here that that's not inevitable. One of the things that we did is to look at the way that they're using it, and this sort of gets a little bit to several of the things I didn't think were quite right, and sort of help spur on subsequent work. I'll point to the little thematic and then sub-themes of orientation and direction. What do we need to be paying attention to? And goals and hopes were a clear area that they kept coming back to. And that's sort of going to dovetail with the idea that Nick had, that there's more in that bucket of goals and hopes than just comfort. We're also going to get to, as we think about feelings and personal accountability, that parents are also strongly working through not just what's best for their child, but what they feel that they need to do to be a good parent. And this was, as I said back, one of the first studies that we did in a cohort study that we had baseline interviews. And defining what is good for the child, even if you're looking at best interest of the child, that requires more effort and work. I will say many qualitative papers spend a lot of time with their thematic analysis. This was useful for me, and I think it has had some relevance to the field, but I'm going to call this a flat theory. This is just a theory of like explanation. It's not dynamic. It's not interactive. It's got these hierarchy of themes, but you don't know how hopes and goals are related to, say, responsibility. It's a fairly flat theory. It's more, and this is going to come off a little bit wrong, but I'm going to say it anyway, it's more show and tell. I can show you what I've done, and I can tell you about it, and I can tell you the conclusions we have reached. But it really leaves it up to the reader to figure out, how does this enter an argument? How would I use this in making my argument for the science I want to do? And if you take on the burden of entering the argument and making it clear that there's general ideas about a simplified model of how parents think about palliative care, and that model is woefully incomplete. Here's a better definition, a better range of things that are going through their minds, organized topically. It starts to have more value to the literature. This is going to attend to the issue of hope is the enemy. This was the same study. Now we're getting to the cohort part where we're actually looking at whether they had a limit of intervention order, a DNR, or several other types of we're not going to do certain thing orders in this cohort that we had followed. Again, I'm breezing through this. So now I'm going into a sort of qual-quant sequential. Again, it's all in one study, so you might think of this as parallel, but because it's cohort, this came subsequently, where we actually are playing with the power of being able to use these two scientific investigation modes in a synergistic way. So we keep coming back to a multi-method, mixed method approach. Here, we actually have evidence that if you are trying to use a logistic regression model to predict whether they are going to put in a limit of intervention order, and you look at aspects that you might think have nothing to do with the child. So the worsening health trajectory is the parent's perception of how the child is doing over time. That's clearly a child-centric effect. And the parents, their subjective judgment, if the child is doing worse, they're more likely to put in a limit of intervention order. Not statistically significant, but the point estimate is positive. If the parents are feeling very negative, using an instrument that the PANIS that looks at negative affect, they're also more likely. And in general, this dovetails with what we know about decision making, that you're more likely to change from the status quo to a new path based on the input of negative emotions. And conversely, if you feel very good about something, you're likely to say, I'm good, I don't need to make a change. So positive affect being very high, and they are not mutually exclusive. You can have both positive and negative affect dialed up. They're not treble and bass that are completely traded, or a volume that's completely traded off. They are treble and bass. But the most important predictor, the most influential predictor, was the more hopeful parents were on a standardized hope scale. That had the significant effect of actually escalating their odds of putting in a limit of intervention order. This is a small sample size. I'm not going to try to make this into more than it is, but it does fly in the face of the theory that hope is the enemy. Here, hope was actually a facilitator, if you want to think of it that way, towards actually moving to a limit of intervention order, which is what, based on clinical experience, I had thought might be the relationship. Goals of care amongst patients and children receiving palliative care. This was a much bigger cohort, multi-center, and we're going to look at the question that sort of Nick posed of where does quality of life fit, where does comfort fit in the hierarchy of what people might be prioritizing. Again, you can look at the citation statistics, and this is a mixed method of qualitative and quantitative. We had done the qualitative work to identify that there are an infinite number of goals that people might wish to pursue, but here were the 5 that we were tracking over time and in a quantitative way using a discrete choice experiment. And what you can see quite plainly from this is that the goal across the entire population, this is 600 plus parents, that had the highest importance rating consistently was seeking quality of life. Next was seeking health. Third was comfort. And then disease reduction and seeking a longer life were the least important rating, with quite a bit of variation. I always want to emphasize that for some patients, quality of life was rated very low. Those are the circles off to the left. And for some parents, seeking a longer life was the most important. Those are the circles at the bottom bar all the way off to the right. If you looked at this over time, which we were able to do because of the cohort aspect of the study, you can see that in general, the quality of life, the longer you are receiving palliative care services, that tends to become more important over time. The health issue, which many people find flummoxing, I'll get back to that in a second, does tend to diminish after about a year. And comfort does start to stage a increase in its value over time, but never eclipsing quality of life. Health, when we proposed the study, we got a lot of pushback that why would parents of children getting palliative care want to seek health? And we had qualitative work that suggested that a good parent never, ever lets go of wanting their child to be healthy, and that they will think about what that might mean differently, but they are going to hope and want to pursue ways to keep the child as healthy as possible, distinct from life extension and disease, correct disease modification. So if a palliative care team or an oncology team comes in like, oh, you don't have to worry about that, that's just health maintenance, you are not in sync, most likely, with the majority of parents who were in this study. The other thing that can be helpful is to realize the fluidity or the frequency with which people are switching their goals over time. This basically says that if you go back and you interview people 2 months later, 6 months later, 12, 18, 24 months, how many of them have flipped the order of one of their goals, any goal? And you can see the vast majority have done some kind of flipping a goal. What about, well, that's too broad. What about the top goal? Because we really want to know what the main driver is. And you can see there that whether it's because the situation has changed and the child is in a different place, 40% have changed 2 months after the initial evaluation. And that continues to be about a third for the rest of time. That could be lability in the child, or it can be lability in preferences. I think that we have not come to grips with how moment to moment, almost, people will have different preferences. And we tend to solidify, because it's convenient for the goals of care conversations, to think we spend all that energy and time having a big goals of care conversation. That's going to be their preferences for forever. And we've run into many situations where 6 hours later, the patient is suddenly not doing as well as they were 6 hours ago. And those preferences have changed. Have they changed in a way that is no longer accurate in their true preferences? This makes me just wonder what we mean when we say what their true preferences are, because they do not appear to be stable over time. I'm obviously playing around with this concept of different mixed methods and the yin and yang of how they can interdigitate with each other. For those of you who are earlier in your career and you're trying to think of ways to write about this and design, this is a paper that comes out of the implementation research realm by Plinkus and colleagues, and actually provides a couple of charts. I'm not going to go through them in any detail. I just wanted to call them out because I think they can be helpful to actually think about the way that you are going to be doing a mixed methods approach. They also not only talk about how it's set up sequentially over time or what's happening over time, but what the functions of the different types of research are. Are you trying to get convergence to really make you more confident in your conclusions? Do you think that they will supplement or complement each other? Are you trying to expand what's going on, etc.? And there are different ways methodologically to actually think about how you would do the analysis. I'm going to now pivot to talk about theory creation. And here, I'm going to make everybody nervous by actually saying we have no idea where ideas come from. We have lots of conjectures about it. It does seem that creativity is not incrementality. I mean, it can be. You just add one next step. And we talk about a research agenda unfolding in a very deliberative, stepwise manner. But I do think that there's a value for loosening up a little bit when you're trying to think of how you're going to potentially explain a phenomenon mechanistically, like not just why is it happening, which can get metaphysical, but like how is this actually occurring? How are we going from better relationship between me and the patient? How would that lead to a better outcome for the patient? A discussion we were just having with my research group a little while ago. Here I'm also pointing to the importance of then marrying theoretical work with experience and not just getting lost in theory. I have no patience with that. But the yin and the yang I would like to propose is not just about quant and qual, it's about how we develop theories and then we assess them. I think testing can get us tied in knots as to whether we can test the theory. We can use qualitative methods to test a theory that says this never happens. All you need to show is that, well, it did right here, and that theory of never becomes negated. And you can certainly use it to test it in a qualitative way that this theory seems to be fairly incomplete. So you don't use hypothesis testing p-values, but you are logically testing theories with the dialogue that you have with your experimental findings. Here's a paper on how parents of children receiving palliative care use religion, spirituality, or life philosophy in tough times. This is another, you can see that we tend to stick with things that seem to have explained, sort of illustrated, like a kind of data visualization for qualitative research. This is the paper we actually used to Wordle to actually look at the frequency, and this was back in 2010. And subsequently Wordles as a way of actually showing the prevalence or the frequency of particular phrases and titles of themes have become more prevalent. But again, I would say that, let me go back to this. This is unfortunately a flat theory. It shows us what we think is. Again, this has actually been cited because there was such neglect of this whole area that even a flat theory was expansive. It was, again, one of the functions is we're just expanding our concept of what's going on here. I'm going to contrast that, though, with where we start to get a little bit more mechanistic. We had data from prior interviews of parents talking about the decision-making process, this first cohort study. And when Chris Rangillian wanted to do a project, we actually focused on explicit heuristics, not the implicit ones that you may hear about from Kahneman and Tversky, but rather the things that parents say out loud are the ways that they're making decisions. Such as, and a lot of these could be stated as goals, but they're a way of summarizing a very complicated situation and boiling it down. So they can say things like, I want my child to be comfortable. 40%, so even with the dialogue I was sort of having in part with Nick based on his comment, it isn't that comfort isn't important. Here, 42% at some point in the interview said, I want my child to be comfortable. Really rare to have a parent not to say the opposite. So it's always on the list of things that they want to focus on, and they will use it as a heuristic to pay attention to certain things, potentially orient to certain treatment options that would enable their child to be comfortable. They also said, almost the same frequency, proportionally, I want my child to have a quality of life. I don't want my child to be in pain. These are all orienting devices. And you can see here what I think is a little bit better about how we did this is that we started to talk about the 5 primary functions. The prior chart that I showed you based on that review paper was the functions of quant and qual. Here, what we're looking at are the functions of a heuristic. Is it to basically depict a situation, or a heuristic that is really important in a confusing situation is what am I going to focus on? And what is going to be my true north? And how, in retrospect, might I justify the choice that I made? And you can see that some of these are ticking different functions. Now, this is a theory. I'm not sure that this is right. This is something that we put out there, a way of thinking about what might be going on. Another theory that we had was that I can walk into a room, many people have this, and sort of talk to a family and get a sense of how they're doing. And while I think that is largely true, there was a subtype of parent where I have to admit I would walk out of the room and think they're putting on a brave show. That this doesn't feel like they truly are as good as they're presenting themselves. In my background in history and sociology of science, I was exposed to a lot of sociology, and one of the books that really had a big impact on me was The Presentation of Self in Everyday Life. And this concept that we're constantly sort of showing the world, the external world, a bit of a persona. Why am I dressed in a jacket? I don't have a tie on. Like I didn't spend, trust me, I never spend too much time thinking about what I'm going to wear, but I did spend a little bit of time thinking about it. We're constantly cultivating an image. And often unconsciously doing it, including the way that we speak to each other and the words that we use. So we were able to take basic transcripts from interview studies that we had done and do a mixed method where we're now going to use the LIWC, the Linguistic Inquiry and Word Count software that was developed by Pennybacker, a famous journaling researcher, does a lot of work on what people write, to actually look at words that are either in the software from the transcript, just the parental snippets of what they said. Are they using more positive words or negative valence words? And what we see is that the easiest to look first on the right side at the negative emotional expression. As they start to use more negative words, and it's fairly flat, there's a little bit of a suggestion that it's the more negative words you are using, then the output of negative self-reported affect on the PANAS. This is the parent not talking to us, but rather privately saying what feelings they were having over the last week. They reported more negative affect the more negatively they spoke. It's not a strong relationship, it's not significant, but it's heading in a direction that sort of more negative feelings, more negative talk. And you could decide which one you think is the independent and dependent variable. But that's very different than what's going on with positive statements. The more positive emotional expression was being produced by the parents, ironically, counterintuitively, they tended to have less internalized positive feelings. So this actually sort of confounds an assumption that people have, maybe. I think our more sophisticated clinicians sort of understand this, that parents have a difficult tightrope to walk where they have to figure out how to engage the team. So I'm not saying they're being disingenuous. It's that we just have to not have a naive interpretation of the way that they are presenting themselves as reflective of what they might be feeling underneath that. Developing parental identity in the neonatal intensive care unit is very recent work that we just had published in the NICU, where Kate Schwartz, an incredible NICU fellow, and KP Callahan, another NICU at the time fellow, now faculty here, and others who have joined on the project. Karen Crew, my longstanding research coordinator, thank God for Karen, and Maya Williams, who's working with Kate now up at their institution up in Queens. These were interviews with 25 parents of 20 NICU patients. And again, I'm not going to do this paper justice, but this is theory generation of what does it mean to develop a parental identity. I call this a first draft theory of processes and events, that there is medical care, there's communication between the infant, the care team, and the parents. They're sort of the actors in this interactive. There's bonding between the parent and infant. There's medical care that the care team is providing the infant. There's communication going back and forth between the parent and the care team. And there were these clearly identified by the parents in the interviews, things that happen that are relevant to the formation of parental identity. Performing physical care activities, a shift in expectations over time, encountering transition points, moving potentially out of the NICU, going to the general wards, or a crisis, the baby gets much sicker. A kind of pervasive sense of the value of just time and presence and how it all sort of experientially feels. And then the feeling of being recognized not by other people so much as by the baby itself. Again, I'm not going to be able to go into the way that we presented this. I am going to say that we clearly went out of our way to make the graphics in this paper at a higher level production grade. We worked with our medical illustration team, which was quickly able to really take this from being something that would have been, it would have been fine, but I think there can be some advantages to upgrading the presentation of results. And we took pains to actually, because the parents had taken pains to say that parental bonding is related to, but different from, parental identity. And the literature in the NICU is mostly about bonding and how to strengthen bonding. And that's definitely part of what's going on in parental identity, but there are a lot of other things that are going on with parental identity that do not have anything to do with bonding. So we're missing, if we focus only on the bonding, we're shining a spotlight on one area of what might be going on, but not enough. Regoaling is we're going to get to the most complicated, a much more dynamic theory of how thoughts of the illness trajectory and positive, negative affect and hope all fit together to do what we call regoaling, which is a way that we all do every day. I'm sure, Shmita, you've actually already encountered this. If you go with one set of goals and then the situation changes and you realize what's possible and you figure out how to help convince people, it's time for us to think of a new way of doing this. We encounter it in career decisions. We encounter it in all walks of life, all areas of life. And palliative care is largely around the parents came into the hospital with one set of goals. We're realizing there are real constraints on achieving cure or lasting remission or what have you. How do we actually embrace new goals? And it's a dearth, a remarkable absence of theory in the space of what are the processes that people engage in emotionally and cognitively to critique a goal and realize, okay, I need to let go of that goal and create a new goal that I'm going to pursue. I'm pointing to development, maybe refinement would be a better way. So the theory is developed, but it could be refined more. And this will be the good parents' belief. Work that initially was done by my dear colleague, who I am totally blanking on.
Pam
Now,
Hines.
Pam Hines, thank you for the rescue there, Emily. At DC Children's, and Pam had done it at St. Jude on actually the title of Good Parent was something that the parents actually came up with. I had done something sort of convergent evolution. I thought of it as what loving parents thought that they needed to do. And we worked together to actually think about how we could do a qualitative into quantitative study. So this is the quantitative piece, again, using discrete choice experiment of refining what Pam had done and what I had done. We sort of combined them. We came up with 12 possible targets that parents had talked about that they were interested in pursuing. And this is what we found, that making sure my child feels loved. So the intuition I had about something there that parents are constantly feeling that they need to make sure that they manifest love for their child turned out to be very highly rated. I don't think that the actual rank order is important as the variation. Different parents have very different sense of what is most important for them to be a good parent. So you have to have some dialogue, some kind of approach to raising this as a topic with parents and being able to talk to them about it. I'm not going to go into okay, this is, sorry about that. It's the wrong, all right. I'm going to exit and just conclude. We've reached the end of what I had intended to talk about. I had taken a slide deck that was about RCTs and how we can interdigitate, and I built off of that. The issue with what I hope you take away, I had a junior faculty member who had done a lovely qualitative project and was having trouble getting it placed. And we talked about what argument are you entering? Because they kept coming back to, well, what does this mean? The meaning of our qualitative work is it's changing the way that we are thinking about something. I don't care if you've done grounded theory, and that's only going to impress people who are into that methodology. What the typical editor and readers want to know is, based on whatever you've done, however you've done it, what should I be thinking differently? And that is where I'm coming back to this idea. You have to enter the argument and present your work as, I think we shouldn't have that assumption. It's too limiting or it's incorrect. I think that we should start to play around with a different set of ideas because they seem to be more capable of explaining how something actually occurs. So I hope that this talk has been useful for you. I think the yin and yang of both quant and qual is very powerful, but even more so underneath that, between the work that we do and the theories that we're working with, I think becoming more comfortable with that can really supercharge the work you're doing. Thank you.
Thank
We
you
have
so
actually-
much. Go ahead.
No, Wendy. I just wanted to say we have no time for questions because you do need to go. I'm sure there are people who have tons of questions, and if we sent them to you by email, would you be willing to take
Yes.
a look at them?
If you compile them, I'll then answer all of them and then you can send them back out. I can do that by the end of today. Happy to do that. And I
That
do
would be
apologize.
amazing.
Thank you for respecting this. Unfortunately, as a division chief, I have a variety of impingements on my time, and I have a noon meeting I have to go get ready.
Absolutely.
Yeah.
Emily, do you want to say a little last word before we let him go? In 2 seconds, 2 seconds.
No, just really appreciate you taking the time to be here, Chris. And I think just learning so much more and more over time about the power of qualitative work and how we can integrate it into our work and really answer some important questions. So
Yeah. Excellent. All right, everybody.
All right.
Yeah.
Thank you so much. Have a
Thank you
great rest
so
of your day.
much.
Bye.
Thank you.
Okay.
And those of
Bye-bye.
you who have questions, send them to me and I can send them out to get those answers.
Thank you, Wendy. Thanks for organizing it.
Thanks, everybody. Bye-bye.